it's Deborah. We met, and I'm a licensed CASAC and LADC in both the state of New York and the state of Maine, and a licensed SAP through NADAC. And I'm coming to you today from a point of speaking about women in recovery and how to reduce the stigma and what we can look for as professionals. I do not claim to be a physician. I'm not dispensing medical advice. I am synthesizing available information from literature for the purpose of teaching the behavioral health professional about treating clients with substance use disorders. I graduated from Summit Bible College in 2010 with a doctorate in Christian counseling. I have a private practice as a Sweetser affiliate in the state of Maine. I'm licensed, like I said, in both New York State and Maine as a substance abuse counselor, and I'm licensed as an SAP through NADAC. I'm a mediator and ordained minister in the state of New York. The resources that I used are listed on this page, as well as experience of having over 25 years in the field of substance abuse. What you will learn today is what is stigma, what are the issues, what are the gender differences between men and women, what are co-occurring disorders, what is trauma, how does it impact substance abuse in women, what are common drugs of abuse, what is the brain chemistry of addiction, a little bit about alcohol and pregnancy, what the ACEs is for women, and some codependency issues, some healthy boundaries, how to reduce stigma, and we will do a case study at the end, which you can answer as part of your homework. The words stigma, when we think of the words for stigma, we think of drunk, addict, crazy, Looney Tunes, she wants the problem, she could change if she wanted to, and there's a myriad of other words that we can say that are more derogatory or maybe even less derogatory. But the stigma around addiction and women in addiction is shameful because most people think, well, she could be a good mother if she weren't using. So there's a lot of stigma with women in addiction. The actions that we have as a society towards people in addiction are avoidance, distancing, and giving them ultimatums if they're family member or loved ones. Some of the emotions that we may feel are intolerance, frustration, anger, being scared, disgusted, and having sympathy. So this is an optical illusion, and that's what I call addiction. It's an optical illusion. On the outside, we see the person who has a substance use disorder, and that's the only thing we see. But on the inside, we might not see the real person. So you can say of this picture, you could type it in the chat, or you could look at it as either a rabbit hopping or a duck. So depending on your frame of reference and how you see it, you can see it as two things. And if it looks like a duck, quacks like a duck, then it is a duck, but it might be a rabbit instead. So, you know, it's based on your frame of reference. And that's what stigma is. It's really just an opinion. It's our own opinion formed by society, maybe without having some education to back it. And not as addiction professionals, we don't see it, but people that are in family members or society kind of stigmatize addiction. I've done a lot of work with women with trauma issues and domestic violence issues, and there's also, we'll have a discussion about that today, but there is also a lot of stigma around those issues. So stigma is a negative set of beliefs that a society holds about a particular group of people. And according to the World Health Organization, stigma, and I say this in quotes, is a major cause of discrimination and exclusion as it contributes to the abuse of human rights. And why do people feel stigma? They feel it maybe because their race, maybe because of their color, their religion. It could be because of their disability, their family status, being divorced, being a single mother could cause stigma. Their national origin can cause stigma. Their sexual orientation can cause stigma. Their physical or mental problems can cause stigma, and substance abuse issues can cause stigma. So this is why people feel stigma in society, and there's probably many other reasons, but these are some of the key issues. So the key elements of stigma for the person that feels the stigma is they blame themselves for being whatever they are. They judge themselves in light of what other people think about them. There's a general mindset of globalization surrounding stigma. Sometimes it's a societal view that causes the stigma. It criminalizes classes of individuals and people. You know, a certain ethnic group or a certain class of people is criminalized by stigma. I have felt stigma in my profession because sometimes the person in front of me classes me as them or part of the system and doesn't look at me as an individual counselor, and I have felt that stigma before. There's pathologizing. We look at the pathologization of stigma and how that relates to our society. Patronization, we patronize people that are specific classes or specific races. There's a lot of fear on both sides of the stigma for the person that's being stigmatized, and then there's the fear factor on the other side of the person judging or stigmatizing that class of people because they're afraid that their class of people is going to be infiltrated negatively by that stigma. Stigma isolates people. It keeps people away from other people. We've seen a lot of that this past year in 2020. Hopefully 2021 will be a better year. We won't see so much stigma, but it isolates people. It steers people towards different locations. In the real estate profession, it's illegal to steer people towards specific neighborhoods, but it kind of does that outside. You know, it steers people towards, you know, low income housing or separate areas to live in the community. Stigma steers people, and that's illegal. There's a lot of anger over stigma. I myself do not agree with stigma, and you know, the anger issues that happen inside, we have to counterbalance as counselors because sometimes we can be stigmatized or we can feel the pain in countertransference of our clientele being stigmatized. There's a lot of demoralization. When people are stigmatized to a great extent, they're demoralized. We look at slavery in this country and how that demoralized people. Professional stigma. I'm talking about professionals. How can we have stigma against others? 3 out of 4 people who suffer from a behavioral health problem reported that they are stigmatized. So how can we do a better job of looking at that? How do we stigmatize as professionals? We group people. I myself have, you know, grouped people in the past in my mind, treating a client as less than what they're worth. Misdiagnosing a client often stigmatizes a client. Avoidance, trying to avoid that client at all costs because they're of a specific class, race, gender, or mental health diagnosis, or even a substance abuse diagnosis. It's like if you're a counselor and you don't deal well with people with opiate addiction and you're a substance abuse counselor, you might have some stigma around that opiate addiction that you need to look at. And then there's also the countertransference guilt. You know, we feel as substance abuse professionals, we can sometimes get the countertransference guilt of, you know, gee, I have to, act differently towards this person because they've been stigmatized their whole life. So we get this overwhelming guilt. And sometimes not believing their truth stigmatizes them. So we have to look at, is that effective, not believing them and not judging them? That's also part of how we stigmatize as professionals. So here are some gender differences in substance abuse between men and women. This is from a NIDA study. Women face unique issues when it comes to substance abuse use, in part influenced by their sex, differences based on biology, the way the brain functions, the way the body functions, the way the emotions function. The gender differences based on culturally defined roles for men and women. We have to look at the culture of the climate here and what is the specific cultural role for either that man or woman, and are they stigmatized in that role when they're using substances? The inability to share or disclose due to trauma in their lives and domestic violence. Women sometimes don't disclose because they're afraid of threats that their batterer has made against them, and men sometimes don't disclose because of the stigma surrounding being abused by a female or even a male counterpart, that they feel ashamed, they feel they should be able to defend themselves, so they feel stigmatized in this. Women have been prescribed treatment that is not proven effective for women. In the past, putting women on the hot seat is not an effective form of treatment for them. They have not gotten the appropriate levels of care because of some of the issues that surround their addiction, whether it be childcare issues or loss of housing or having to be a stay-at-home mom. They haven't got the treatment that they need. And research has shown that women use drugs differently. They have different use patterns. They respond to individual drugs differently, and they have unique obstacles to overcome in the treatment setting. So we're going to look at some classifications of drugs. Marijuana, which is a sedative, called cannabis. Fewer females on the whole use marijuana than males, but it is a rising number today. The effects can be different than for male users. Women tend to have a greater emotional drive than men do because of the size of the amygdala in the brain, but marijuana impairs spatial memory in women more than it does in men, while men show a greater marijuana-induced high. So it does impair the spatial memory in women more, and men have a smaller amygdala, so they have a more marijuana-induced high. Women tend to use marijuana to treat panic attacks, anxiety disorders, pain issues, and as a result, the marijuana disorder develops more rapidly. There's a lot of women who have pain issues related to various medical conditions, also some postpartum depression. They use marijuana to cope with anxiety and stress and then develop a more rapid onset to the addiction. Stimulants and cocaine and methamphetamine, women are more vulnerable to the rewarding effects of the stimulants, and estrogen is possibly the one factor for this increased sensitivity in women. And women are inclined to be more sensitive to cocaine effects on the heart and blood vessels, and female cocaine users show similar deficits in learning, concentration, and academic achievement. This is the motivators for use for methamphetamine between men and women in a percentage. Those that work more, men tend to work more when they use methamphetamine. For weight loss, women use more methamphetamine. That can be tied to eating disorders as well. For escape, men use methamphetamine as a motivator more than women. To stay awake, women use a slightly higher percentage of methamphetamine to stay awake than men. For energy, women use methamphetamine almost 20% more than men. To get high, women use methamphetamine more than males. And for better sex, men use methamphetamine more than women. Benzodiazepines is another class of drugs that produce sedation. They help with sleep and affect the central nervous system. They're usually benzos, downers, nerve pills, tanks. Those are the street names for them. They're taken orally or crushed or snorted. I have known people to inject them. It calms and sedates the body. Benzos taken in larger amounts or over longer periods of time can produce disturbing sleep and dreams, amnesia, or irritability. There is an overdose warning that I've mentioned here. Do not mix with alcohol or opiates because it can shut down the central nervous system. And you have to be careful when working with your women, especially because a lot of them have been prescribed benzodiazepines for stress and anxiety disorders, and also have opiate or alcohol issues. So you have to watch for that diagnosis and watch their prescriptions and make sure you're talking with their doctors. The exact mechanism of the action of the benzodiazepine is not known, but they appear to be working by affecting neurotransmitters in brain, chemicals that nerves release in order to communicate with other nearby nerves. So one of these neurotransmitters is gamma-aminobutyric acid, known as GABA, not to be confused with gabapentin, which is a medication, a neurotransmitter that suppresses the activity of the nerves. So GABA is a neurotransmitter that suppresses the activity of the nerves. So that's how the benzodiazepine works. It works with GABA to suppress that nervous agitation and that activity of the nerves in times of high stress. Opioids, women are more likely to become addicted to opioids because of chronic pain issues. There's a high rate of dependence after a small amount of opiates are used for a less amount of time. There's more use of more potent opioids for longer amounts of time. And they use opiates for weight loss and to regulate weight, use opioids to cope with emotional pain and trauma, and to cope with sex trafficking and sexual trauma. The danger with opioids, again, I will say, is to always look to see if they are using opioids in connection with benzodiazepines and alcohol use, which could cause central nervous system shutdown and overdose. Opioids and pregnancy. When pregnant women are on opioids or opioid agonists, then they can face serious problems because the baby can be born dependent and need withdrawal. Women tend to be treated with methadone or buprenorphine maintenance, combined with prenatal care and a comprehensive drug treatment program can improve their health outcome. And many of the adverse outcomes associated with untreated opioid use include low birth weight, children born in withdrawal. Injecting opiates can cause endocarditis, which is the collapsing of veins, which can lead to heart failure, stroke. Babies can be monitored for drowsiness, inadequate weight gain, and failure to meet developmental milestones when they're younger and exclusively in breastfed infants. So if a woman is pregnant, it is advisable for her to go on Subutex, methadone, buprenorphine to help with those symptoms so she's not injecting opioids and causing further damage to the infant nervous system and brain. There's national drug overdose statistics by the Center for Disease of Control and Prevention, the National Center for Health Statistics, and we look at the number of overdose deaths from 2001 to 2017, and we can see that the male line is the white line. They are more apt to overdose from opioids and drugs, and the female line is still rising, and it's still about at 20% of the national average of opiate deaths due to drug use. We're going to talk a little bit about the brain and some of the pathways, the functions of the brain. So we see that the dopamine pathways is the blue line. So if we look at the blue line here, I'll make it in yellow. This is the dopamine pathway in the brain, and it goes, we can see it goes to the prefrontal cortex, which is responsible for our decision-making process and part of our memory. And it also is in here, which leads to conduits in this part of the brain, so which is the striatum. And then we see the serotonin pathway of the brain, which I'll make in green. It starts here and then follows out with its neurons to basically the back of the brain, which is located here, which would be the cerebellum part of the brain in the parietal lobe. So this is responsible for our thinking, and this is responsible for our balance. And here we see the brain stem, which is also a serotonin pathway. Now, the limbic system, or the dopamine pathway, the mesolimbic system pathway, this pathway is a conglomerate of the primary limbic brain, and all nerve axons in the mesolimbic pathway communicate using dopamine and therefore are known as dopaminergic neurons. So we see the dopamine pathway here, which we saw in the, I'll make it in green, which we saw in the brain before. The dopamine pathway is here, and it is responsible, it comes out of here, this area, which is known as our amygdala. So it's also, this is our pituitary gland here, which is the major gland of the body. So our hypothalamus is here, which regulates our temperature and our body. And then we're looking at the front part of the brain where the dopamine lands. This is the frontal lobe, which is responsible for our decision making. So when we use drugs, it affects first the amygdala and then comes out and affects the dopamine pathway. We do not have enough serotonin to help us, and our serotonin levels wind up decreasing. So when we look again at the front part of the brain, this is the cerebral cortex or frontal lobe right here. This is the thinking part of the brain where logic and judgment reside. It is the outer portion of the brain and divided into lobes. Think of the cortex in the strategy of the center of the brain. The limbic system, which we showed you before, is the emotional center of the brain, which is located in the lower brain and considered to be more primitive than the cortex. The emotional expression is not using the thinking cortex part of the brain, but primarily the limbic center of the brain, or the emotions, which is in here, which is the amygdala. So your cortex is the whole outside of the brain, which is separated into lobes: frontal lobe, parietal lobe, occipital lobe. And then you have the mid part of the brain, which is where your amygdala is housed, and the emotions. So looking at the differences in men and women when it comes to the brain, the male uses the left hemisphere of the brain more predominantly, and the woman uses both hemispheres of the brain simultaneously. The thinner parietal region of the brain gives easier visualization and spatial abilities to the man. The language part of the brain is more enlarged in the women, and that's why women have more language area in their brain. The smaller hippocampus in the male, their reactivity to stress is greater because the GABA production is down. The larger hippocampus and deeper limbic system has women feel emotions more deeply. The larger inferior parietal lobe in the male causes the male brain to have a higher mathematical ability than the female brain. The thicker corpus callosum, which actually joins the brain together, is the neural circuit in the average female brain, contains a larger number of connections between the left and the right hemisphere. So the corpus callosum goes down the midbrain and it connects the two hemispheres together. And that's why women can use both hemispheres simultaneously, because they have a bigger corpus callosum and they multitask a lot easier than males. In the IQ cluster, males either score high or low, and women tend to scale in the mid-level of IQ. In men, the parietal cortex, which is involved in spatial perception, and the amygdala, which regulates sexual and social behavior, are larger, and men seem to think that with their gray matter, which is full of active neurons, and women think with the white matter, which consists more of the connections between the neurons, and women tend to be able to multitask more easily. Alcohol, because it's socially acceptable, because they're of legal age. Alcohol is romantic. It's associated with a quiet romantic dinner. Women like to feel that emotion, that connectivity by using alcohol. It affects their emotions. It causes them, when they're sad, to be happy or comfort them. It also institutes power. There's power in using alcohol because people feel that they can be more capable, more social, more outgoing. It sometimes helps women solve their empty nest syndrome by drinking alcohol. They don't feel as lonely. They drink because of the stress of divorce and relationship issues and the emptiness that causes. And it could be just workplace culture that everybody goes out for drinks after work and they join in for socialization. Alcohol is easily hidden and it helps cope with stress and anxiety. Alcohol itself binds directly to the receptors of acetylcholine, serotonin, GABA, and glutamate. It enhances the activity of GABA, effectively turning cells off longer and decreasing their activity. So GABA is in our brain to create that homeostasis. Without the essence of GABA, we don't feel regulated, and that way we can either have an extreme flight, fight, or freeze response. It reduces glutamate activity, decreasing efficiency of the neural responses and decreasing balance and coordination. So without that homeostasis of GABA in our body, that's why we get decreased balance and coordination when using large amounts of alcohol. Health effects of alcohol use on women. Women have a higher risk for liver disease than males, especially cirrhosis. There's an impact on the brain. The cognitive decline in the brain accelerates more quickly in women who use alcohol, and the impact on the heart is greater. There's a greater risk for heart disease than males, and in lower levels of time. Breast and other cancers, alcohol increases risk of cancer of the mouth, throat, esophagus, liver, and colon, and the breast in women. Alcohol use and pregnancy can result in fetal alcohol spectrum disorder. It's a term that includes fetal alcohol syndrome and partial fetal alcohol syndrome, alcohol-related disorders of brain development, and alcohol-related birth defects. The prevalence of fetal alcohol syndrome in the United States was estimated by the Institute of Medicine in '96 to be between 0.5 and 3 cases per 1,000 with women who drank during their pregnancy. In fetal alcohol syndrome, characteristics are a lower body weight, poor coordination, hyperactive behavior, difficulty with attention, poor memory, difficulty in school, especially in math, learning disabilities, speech and language delays, intellectual disability or a lower IQ on the whole, poor reasoning and judgment skills, sleep and sucking problems as a baby, vision or hearing problems, problems with heart, kidneys, and bones, shorter than average height and small head size, abnormal facial features, and there's a smooth ridge between the nose and the upper lip. This ridge is called the philtrum. So this is a smooth ridge here in persons with fetal alcohol syndrome characteristics. It does really affect their learning. I've worked with people that were fetal alcohol syndrome that also had addiction problems in my career, and it really does affect how they learn and retain materials. And it doesn't, each case is different. Alcohol causes adverse effects on the brain. In the brain, alcohol affects the production of the neurotransmitters, causing changes in emotional regulation such as anxiety, depression, paranoia, and schizophrenia. And beverage alcohol is a positive allosteric modulator of GABA. So it inhibits the GABA production, which we need for that homeostasis in our bodies. Alcohol increases production of neurosteroids in the body. When we prevent the synthesis of neurosteroids when someone is drinking, there is less drunkenness. So alcohol increases the production, and when we prevent it, there's less drunkenness. So with increased production of alcohol, that's why there's more drunkenness. Alcohol first attacks the forebrain, the frontal lobe, that is responsible for coordination and decision making. Then it knocks the midbrain or the limbic system, where a person loses control of their emotions and increases the chance of blackout. Alcohol batters the brainstem, the central nervous system, when heart rate, breathing, temperature are affected, producing a fatal condition if alcohol is consumed in great quantities. And the BAC reaches a 4.0 or greater capacity. Now we're going to talk about some treatment program choices for women. They can go to detoxification, usually in a hospital-based or sometimes there's ambulatory detoxification, depending on what drugs they're using. That detoxification is short. Most women will go to detoxification. However, they prefer outpatient to inpatient treatment just because of childcare. When they go to inpatient treatment, there are some issues surrounding childcare and sometimes it's harder for women with children to go into inpatient treatment. Residential also poses those issues. However, some residential programs are now allowing women to bring their children with them, which is wonderful. And sometimes when you find one that isn't, children are placed in the foster care system if there is no kin or relative that is willing to take them. Medically monitored means that they're using opiate agonists such as naltrexone, naloxone, buprenorphine. They're using these to help with their addiction issues. Suboxone, methadone. The issues for women in treatment is working and going to treatment because of family or children and their obligations in the home. Pets often stop women from going to treatment. Their responsibilities, some trauma, they may have experienced trauma in treatment or are afraid to be in a environment with many people. Co-occurring disorders can prevent them from going to treatment, not being able to treat those, or may cause them to not get the correct treatment. Some self-harm issues may cause them problems in treatment, and domestic abuse coercion causes them to leave treatment early. Setting boundaries is difficult in treatment settings for women, especially when it comes to home and family. The risk for women in treatment is a loss of family, children, and pets, thinking errors, treatment options, loss of housing, need for the employment and education, child protective services, foster care versus having a family caregiver, and state services for rehabilitation. Some of the thinking errors are denial. That's not realizing that they have a problem, rationalizing their problem, trying to figure out why they have a problem, why they do what they do so they can keep on doing it, and justifying, making excuses for their problem. Some transference issues, they may have transference issues at home. They may have transference issues in the treatment center, and that's looking at those. They project thinking that they never will be able to get the help that they need, and that it's a futile condition. They may have resentments that build and prevent them from getting the effective treatment that they need. These are all thinking errors that women can look at it in treatment to help them recover. Another issue is loss of housing. What is it going to be like if they have to move in with family, maybe leave a domestic violence situation? What are the residential placements going to be like? Are they going to be able to cope with being away from their family for a substantial length of time? Women have fear of going to shelters because of sexual predators, temporary housing. They have fear of not having adequate housing for their families. They may need specific case management skills to help them with their finances. And there's a lot of emotional implications with the loss of housing and being able to provide for your family. Co-occurring disorders occur in anyone, not just women, men as well. And the term co-occurring disorder means a mental health disorder that coexists with at least one substance use disorder in an individual. Patients in treatment who have co-occurring disorders often exhibit behaviors or feelings that interfere with treatment. They may be feelings because their mental health condition is unmedicated or untreated, and it may not even be diagnosed. They may come into treatment without having a pre-diagnosed mental health condition. And symptoms may include the presence of both independent disorders and self-induced disorders, such as eating disorders, along with substance use disorders. Patients may have identifiable co-occurring disorders on admission to an outpatient, or disorders may emerge during treatment. That's why it's good to always screen your patients and continually be screening them and looking and observing their behaviors to see if they need some help with their mental health disorders and getting treatment for those. Dual diagnosis in women, which is what co-occurring disorders are comorbidities with substance use disorder. And some of them include self-injury, eating disorders, mental health diagnosis, personality disorders, domestic violence, sexual trauma, and trauma. Self-injury is the most common in females ages 11 to 16, and it can continue into adulthood, especially to victims of sexual abuse. Scarring is a deliberate injury to one's body that leaves the mark, scarring. Clients to release tension and cope with self-hatred is a way to manage their emotions and express intolerable feelings, to distract from other problems in life, to communicate needs, to create visible and noticeable wounds, to purify themselves, to reenact a trauma, and to solve it or afflict pain. So what they do is they reenact the trauma and then they cut or they self-abuse after that. Self-injurious behaviors include burning the skin, cutting the skin, inserting objects under the skin, self-inflicted wounds, headbanging, punching self, drinking harmful liquids, tattooing or piercing self, eraser burning, and subdermal tissue scratching. Eating disorders, we're going to talk a little bit about that because predominantly a lot of women in treatment have eating disorders. We're finding that it is increasing more and more. It's an obsession with food. It's being obsessed in some form or fashion with their body weight. They have obsessive thoughts about their body shape called body dysmorphia. They have negative self-comparison to other people. They have a denial of bodily changes as a result of the eating disorder. They have purging, excessive exercise, binge eating followed by purging, or eating of no calorie foods, such as I've had patients that just eat straight butter. Avoidant restrictive food intake disorder. This is in the DSM. The diagnostic criteria is an feeding disturbance with a lack of interest in eating, avoidance on food based on sensory characteristics in the food, and concerns about adversive consequences of eating as manifested by persistent failure to meet certain nutritional or energy needs associated with their significant weight loss, significant nutritional deficiency, dependence on enteral feeding and oral nutritional supplements, marked by interference in psychological functioning. Anorexia nervosa has been in the DSM for a while. It's a restriction of the energy intake relative to the requirements, leading to a significant low body weight in context of age, sex, and developmental trajectory and physical health. It is the intense fear of gaining weight and becoming fat, and it's usually followed by a binging, purging behavior. There is the restricting type that is not engaged in recurrent episodes of binging, purging in the last 3 months, but the weight loss is accomplished through severe dieting, fasting, and excessive exercising. And then there's the binge purging type, which is usually more common and lasts 3 months, and the individual engages in efforts to binge and purge the body of excess calories through the use of diuretics and laxatives and vomiting. Bulimia nervosa is eating over a discrete period of time, a large amount of food that most individuals would not eat in that amount of time. And it's a lack of sense of control of eating. It's binging and eating whatever in sight. A lot of bingers don't even remember what they eat, but they eat in large quantities. Self-evaluation is unduly influenced by body shape and weight, and the disturbance does not occur excessively during periods of anorexia nervosa. So people can have anorexia and bulimia at the same time. Binge eating disorder is characterized by recurrent episodes of binge eating, eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food when not physically hungry, eating alone because of the embarrassment of the amount the person is eating and feeling disgusted, depressed, or guilty afterwards. And a marked distress is present, and it occurs at least once weekly for 3 months. And it's not associated with any neurocompensatory behaviors. Other specified eating disorders that are in the DSM is atypical anorexia, all criteria met, except that the individual is in the normal weight range for their body. Bulimia nervosa, all criteria met, except that the duration occurs less than once a week or less than 3 months. Binge eating disorder of low frequency or limited duration, all criteria are met except it occurs less than once a week or less than 3 months. Purging disorder, recurrent purging behavior to influence body weight, shape, or gain in the absence of binge eating. Dangers of eating disorders and substance abuse disorders is a loss of health to recover. People, if their eating disorder goes up because they're working on their substance use disorder, their loss of health to recover goes down. The fear of loss of control, a lot of that, what we talk about in substance use is being willing to be able to lose our control and powerlessness, and that's scary for most people with eating disorders and substance use disorders, so they try to control one while they're working on the other. Denial or avoidance, they don't want to look at it themselves. There is some manic behavior that occurs with an eating disorder, and feeling like they're lost and they need to, again, control and regulate themselves in some way. Suicide ideations occur with eating disorders because they don't like themselves. They also occur with substance use disorders because the person has such low self-esteem and depression. So we have to look for that, especially in women. Obsessive exercise can be an indicator of some of the dangerous risks in substance abuse. One of the key indicators to increase serotonin levels in the body is to exercise, so we usually talk about that. But to someone with an eating disorder, that's just the green light to be more, exercise more so they can lose more weight and control that way. Poor self-esteem, control over trauma symptoms. People use eating disorders to control their trauma symptoms. And limited psychological and emotional functioning. When the brain is not getting proper nutrients because of the eating disorder or because of the substance use disorder, because people aren't eating when they're using, then there's limited psychological or emotional functioning. Mental health disorders. Common ones are anxiety, depression, PTSD or acute stress disorder, adjustment disorder, bipolar disorder, disruptive mood regulation disorders, and personality disorders. These are common in women in treatment. Domestic abuse includes both physical violence and emotional, sexual, psychological, or financial behavior between intimate partners or family members, which is controlling, coercive, or threatening. It's a cycle of control of the substance, to cope with the abuse, to join with the abuse, to have avoidance problems. They want to avoid the abuse. It could be because of compliance problems. They want to comply with the abuse and regulate it by using. And it also because it's a lack of self-esteem. Domestic abuse causes a female to have a lack of self-esteem. Sexual violence is a significant problem. It refers to sexual activity when consent is not obtained or given freely. Most of the victims are females, but anyone can encounter sexual violence. A person responsible for the violence is typically male and usually someone known to the victim. The victim can be drugged or groomed with the use of substances as part of the plan to initiate the violence. Drug use can ensure the violence because of unresolved guilt and shame. So it can ensue after violence because of unresolved guilt or shame on the part of the victim. Post-violence addictive issues are often coping mechanisms for the abuse itself. Digital Munchausen is a syndrome by proxy. It's a factitious disorder imposed on another. It's a psychiatric disorder who describes individuals who persistently falsify their illness in another, even when there is little or nothing tangible for them to gain from the behavior. And it's a form of self-imposed victimization, posting on the internet to gain empathy and sympathy from others. It's imposed on self, where in those who feign illnesses in online venues. Trauma and substance use. Trauma is cause of physical and emotional harm, which you cannot remove yourself from. It just happens to you. That's what trauma is. In counseling, discussing the trauma point ignites feelings of intense fear or helplessness for women. It brings them back. And it can lead to significant anxiety, depression, or addictive impulsive behaviors. Women stigmatize themselves when they're in trauma, and they use substances to mask the pain, to cope with that abuse. The common substances used by women who have experienced trauma are alcohol, heroin, and benzodiazepines. The Adverse Childhood Experience ACE questionnaire, there is one especially for women that has been created to talk about life areas. This is advisable to do. It would help you know the women that you're treating, and also be able to help them understand why they have some of the problems that they have in their life. And it helps you, it gives you a guideline in how to set their treatment plan so they can improve in their social, emotional, and cognitive functioning. Codependency issues. We stigmatize codependency issues. Oh, I can't be codependent. He just needs my help. You know, codependency is an addiction to people, behaviors, or things. It's doing for people to manipulate or control their environment, situations, or outcomes. It's feeling the need to do for others instead of doing for self. Taking care of others before you take care of your own needs. Person who will have domestic issues and reside in substance-dependent environments can exhibit patterns of codependent thoughts and patterns of denial. They deny that there's a problem. They comply with the abuser's demands or the other person's demands in order to not have any abuse. Or they try to keep them from using or from drinking and wind up drinking and using themselves to cope with the stress. There's control. They like to control the environment of others because they can't control themselves. And they generally have low self-esteem. So when we talk with women who have had stigmatization, have had stress, have been not willing to go to treatment, we wind up talking about some unhealthy and healthy boundaries. So when we're looking for unhealthy boundaries versus healthy boundaries, it's inappropriate self-disclosure rather than appropriate self-disclosure. Women often find themselves in predicaments because of inappropriate self-disclosure. They tell all too often or too much. And a healthy is to be able to have appropriate self-disclosure and not reveal those things about yourself so you're not judged or stigmatized. Inappropriate social cueing is unhealthy. And self-discretion is a healthy boundary. Inappropriate social cueing is when they misrepresent the social cueing of other people because they have been stigmatized in their life. Unhealthy is having emotional outbursts, and a healthy form of boundaries is having appropriate expression of emotion, which can be taught to them through cognitive behavioral therapy, rational emotive behavioral therapy, and dialectical behavioral therapy. Unhealthy is having a victim mindset. Everybody's doing it to me. That's a form of self-stigmatization. And a healthy one is having a survivor mindset, being able to move forward and go forward with their recovery with a healthy sense of a self-esteem. And unhealthy is being the problem. That's stigmatization. They see themselves as the problem. I work with a lot of mothers that have lost their children for many years in New York State at a female parole house. And what happens is there was some self-stigmatization. I'm a bad mother because I lost my kids, because I used drugs. So a lot of work on looking at how they can be part of the solution and have a healthy self-esteem and less self-stigmatization. Being unaccountable is unhealthy. Teaching people how to time manage and learn to become accountable, and especially women. They have great responsibility when they're raising children or in their lives, individual lives. So having them be accountable and present and in the here and now is part of the therapy that can help them in the future. Steps for change for women. The first step I usually try and do when working with women is help them develop a willingness to sacrifice pleasure for opportunity. The opportunity is an opportunity to change. The pleasure was when they were using drugs and alcohol. And then look at identifying thinking errors. What are they suffering from? Is it denial, resentments, codependency, addictive thinking errors, criminal thinking errors? What are some of the thinking errors that they're control, manipulation, resentment, justifications? You know, what are their thinking errors? And making a daily growth commitment. You know, how can they grow daily? How can they explore their values and make values-based commitments? And then explore their healthy and unhealthy boundaries and doing some work around those so they can build a healthy self-esteem. And we set small attainable goals and celebrate successes. So that's what treatment about is for women. It's effective steps for change for women. Relapse prevention for women is something that every substance abuse counselor should do. We have to look at the behavior changes, learn to think about what are some of the codependency issues I might have to change or encounter. What's my cycle of abuse and victimization? Thinking errors. How do I develop a relapse prevention plan and aftercare plan with these in mind? What are the attitude changes I need to look at? Increasing my self-esteem, my self-perception, values, identity. Who do I identify as? Reducing shame, shield, a shame shield. Do we have emotional closeness or emotional dissonance from events? And how do we reduce those shame shields? Our thought changes, learning positive parenting skills, boundary setting, cognitive behavioral therapy, rational emotive behavioral therapy, and DBT groups and therapy will help women change and give them a healthy relapse prevention plan with a great many coping skills. So a guide to reduce stigma is to avoid labeling, to avoid grouping, treat women who have addictive disorders with dignity and respect, act with compassion and empathy, avoid a sympathetic response, listen without judgment, learn about addiction, replace perception with fact. There's a good YouTube video I linked here that you're certainly willing to watch. It's an excellent one on eating disorders and stigma. This is our case study. What I'd like you to do for homework is do a written answer the questions and written form, a paragraph or two, and let me know what some of your thoughts are and how you can help Jill in the community. So I'll just give you a little overview. Jill is a 40-year-old that obtains a drunk driving charge off base while in port on her off-duty time. There is no U.S. Coast Guard rule that she cannot drink alcohol in her off-duty time. She rented a car and was driving back to her hotel with her boyfriend, and when this happened, she was in a different state when this happened. She is very concerned because she is afraid of her commanding officer and her family will find out. The stigma of being labeled with an alcohol problem weighs heavily for her because she has a high-ranking position. She has 2 children at home, ages 15 and 18, and her husband is a retired USCG and stays home and cares for her children. What kind of stigma is Jill facing? What will prevent her from engaging in treatment for her problems? What would you recommend for Jill to help her reduce her stigma? It's been a pleasure working with you. This is the end. So if you take the test and this is your test, which is the case study, then I will email you your certificate of completion, which is 3 CEUs. Have a wonderful day. It's been nice to work with you, and I hope you join other webinars that we have on CEU for you.